Webinar series. And we have a great topic tonight and a wonderful speaker, Dr. Alka Kanaya, talking about MASALA study inside the MASALA of Insights. And we have a moderator, Dr. Anurag Mehta, who kindly agreed to do the moderation for this session. And we have Dr. Amit Govil, a nephrologist and professor of medicine from University of Cincinnati. He's the CMA chair this year. So I would like to invite Dr. Amit Govil to introduce the speaker and the moderator. Dr. Govil, thank you.
Thank you. Thank you, Dr. Katula. And I saw a message that people are not able to hear. Is that right? Can you hear us before we proceed?
I mean, we couldn't, we did not start anything until now, so maybe that's why they weren't.
Yeah, okay. So it gives me a great pleasure to introduce the speaker for tonight, Dr. Alka Kanaya, who's a professor of medicine, epidemiology, and biostatistics, and a practicing general internist at the University of California, San Francisco. She received her MD degree in 1995, completed internal medicine residency and fellowship training at UCSF in 2001. She focused her research on type 2 diabetes and cardiovascular disease epidemiology and prevention, specifically to identify and understand the causes of Asian American health disparities. She's a lead investigator of the MASALA study that we all have heard about, the mediators of atherosclerosis and South Asians living in America. So it's a community-based prospective cohort to identify socio-cultural, behavioral, and biological risk factors to explain the high rates of type 2 diabetes and heart disease among South Asians. And the MASALA study has influenced US screening guidelines by the American Diabetes Association and the American Heart Association and American College of Cardiology. So it gives us a great pleasure to have the lead investigator of MASALA study giving this talk tonight. And to moderate the session for Q&A after the discussion would be Dr. Anurag Mehta, who's the Director of Preventive Cardiology at Virginia Commonwealth University in Richmond, Virginia. And thank you both, and welcome, Dr. Kanaya. Please take it over.
Thank you so much, Dr. Govil. It's a pleasure to be here again. I think I've spoken at another APIO conference maybe a few years ago during the pandemic, and also in person in San Antonio a few years ago. So lovely to be back, and I'm hoping that I can share some of our new insights from doing the MASALA study now for more than 12 years. I'm going to save at least 10 minutes at the end for Q&A and discussion. I'm sure there'll be a lot of questions that come up. So with that, I'm just going to jump right into talking about how we designed MASALA so that everyone is very clear about what we can answer and what we cannot answer with this study. So MASALA stands for Mediators of Atherosclerosis in South Asians Living in America. And we purposefully sampled South Asian Americans who lived around the San Francisco Bay Area, where I'm located, and the greater Chicago area, where my co-PI, Dr. Nami Kandula, is located. And the real premise of this is really to understand the health and cardiovascular health of South Asian Americans. And we purposefully designed MASALA to be able to compare the South Asian American immigrants to other groups in the United States. To be in MASALA, someone had to be between the age of 40 to 84 years. They could not already have cardiovascular disease. So if they had had any interventions on their heart, even a cath without stent, any kind of procedures, interventions on their heart or arteries, they were not eligible, because we're really looking at what causes heart disease or cardiovascular disease. And to have somebody who already has disease or already has symptoms means that they're already far along in that process, and we really won't be able to understand the antecedents of disease. So as I mentioned, we had enough grant funding to do the study at 2 sites, UC San Francisco and Northwestern University. And to date, it's the only longitudinal cohort of US South Asians. We purposefully designed MASALA to be comparable to the ongoing multi-ethnic study of atherosclerosis. This is a very large study with more than 6,800 Americans who are white, Black, Hispanic, or Chinese, and it had already been going on for 10 years when we started MASALA in 2010, but it was a really good opportunity to work together with MESA to be able to harmonize the measures we're using so we could cross-compare the South Asians to MESA. So we used the same exact inclusion criteria that you had to have no existing cardiovascular disease to be in both of these studies. So here's what we have accomplished in one snapshot over the past 12 years. We did exam 1 back in 2010 to 2013. We brought people in for a 4 to 5 hour visit to do a 2-hour glucose tolerance test, CT scans on their heart and abdomen, carotid ultrasounds, EKGs, and several questionnaires. We brought people back in exam 2 to repeat several of those tests, and we got a little bit of philanthropic funding to add a few more people, another 250 people in exam 1A that we call. We have just completed exam 3 in August of this year, and the focus of this exam was to look at heart function with echocardiogram and other tests of vascular stiffness and endothelial function. I will not be showing data from exam 3 because we're still processing all of the data currently. We also got a new grant in 2021 to enlarge our study population, going from 1,164 people to more than 2,300. And that is by enrolling Bangladeshi immigrants and Pakistani immigrants, because primarily so far, the original participants in MASALA have been primarily immigrants from India, and we wanted to look at differences in risk factor profiles and what may be causing what we know from other countries is a higher risk of heart disease in Bangladeshis and Pakistanis. So I'll just show you a couple slides at the very end with a flavor of the data that we have been collecting in these new participants, and we hope to finish complete data collection by early 2025. So most of the talk is going to be on our original population of MASALA participants. And as I mentioned, 83% were born in India. About 2/3 were born in North India and 1/3 in South India. And you'll see very few people were born in other South Asian countries. And that is why it is so important for us to add more people who have their origins from Pakistan or Bangladesh. Those are the 3 largest South Asian subgroups in the United States. So the patients we see in clinics that we would like to really, understand their risk factors and ways to prevent disease. 2% of people were born in the United States. And if you think back, I told you the age inclusion was 40 to 64. So it includes a lot of people, a few people in their 40s whose parents immigrated here in the 60s or 70s and then started their families in the US. We've just finished doing whole genome sequencing of our original cohort. And what I'm showing you here on the left is how the MASALA population, shown in orange, compares to other known populations by their genetic ancestry. So Africans are shown in blue, Europeans in green, other groups are shown in different colors. And you can see, East Asians are shown in green, Europeans are shown in red. You can see that the MASALA population is distinct with a distinct genetic background that comes primarily from South Asia, as expected. And then when we do a finer map of all the people in MASALA so far, we can use principal components analysis to look at their genetic ancestry. And what I want to show you is that people who were born in North India and in other countries like Pakistan and Bangladesh, they group on one end of this axis, whereas people born in South India, including people born in Sri Lanka, are on the other end, showing there's a continuum of genetic ancestry from north to south in the South Asian subcontinent. And this is very much what we had expected given other data about genetic ancestry of South Asians. There is a distinct cluster here that you will ask me about. This turns out to be Gujaratis. 23% of our study population in MASALA were born in Gujarat. And for some reason, they are clustering a little bit separately from other North Indians, even though it is a North Indian state. So that is very interesting. And we're looking into this to see if there's some reason that there may be some distinction between Gujarati Indians versus other North Indians. Okay, so who is in this study? About half were men, half women, half were, seen in Chicago, and half were from the Bay Area. And the mean age of our study population is 57. They've lived in the US in a kind of a nice bell-shaped distribution, with the mean years about 28 in the US. And so there's some people who are recent immigrants who've spent less than 20% of their life in the US, but people who are greater than 80% of their life in the US. And as expected, the MASALA study population is quite high in terms of educational attainment and family income. And you all are well aware of this. And this is because of the immigration laws that were in effect starting in the mid-1960s, that only people coming here for higher education or with a professional degree were allowed to immigrate. So there's this skewing of South Asians, especially Indians, and the US as being the most highly educated population compared to any other group of immigrants or non-immigrants. So we in MASALA have 86% who have a bachelor's degree or higher, and with that comes a high family income. So these are known, as we expected from the census, and so not surprising. And if anything, you can think about our data as reflecting Indian immigrant populations, because again, 83% were born in India, and they've lived in the US for half their life. So now I'm going to be contrasting the MASALA South Asians in the first column with the 4 different groups in the MESA, our comparison study, to show you, what differences may exist in many of these lifestyle and behavioral factors. In terms of who was currently smoking, the South Asians in MASALA had the lowest prevalence of current smoking, only 3%, compared to the Chinese in MESA, they were at 6%, and the other 3 groups in our sister study had higher rates of smoking. Alcohol use was also fairly moderate in the South Asians and the Chinese, and much higher in the other groups. However, exercise, unfortunately, was the lowest among the South Asians. Now, I already told you they're the most educated and the most affluent compared to any of these groups in MESA, yet the exercise, a very modifiable risk factor, was the worst in the South Asians in MASALA, again, using the same instrument that collected data on exercise, physical activity at work, at home, different types of physical activity, including yoga, walking, amount of time spent in doing exercise related to muscle strengthening, aerobic exercise, etc. No matter how you cut it, the exercise levels were much lower in the South Asians. So in the next 30 minutes or so, I'm going to go through some of our data in terms of what we found for diabetes, what we've learned about body composition, diet, and acculturation, and then I'll end with a few of our papers on atherosclerosis risk. So diabetes prevalence. So in MASALA, we used both a fasting glucose and a 2-hour glucose tolerance test to categorize people with diabetes, pre-diabetes, or normal glucose tolerance. And in the first bar, you can see the total prevalence of diabetes was about 26%. So 1 in 4 people had diabetes. About a third had pre-diabetes. And there's a gender difference, with 30% of men having diabetes compared to 21% of women. This gender difference in diabetes exists around the world. Not very surprising, but in general, this is a lot bigger gap between men and women than what you see in other studies. Generally, it's about a 3 to 4% difference, but the women in MASALA were quite a bit healthier than the men. So how does this compare to our sister study, the MESA study? And in this chart here, I have had to take out the data on the 2-hour glucose tolerance test because that test was not done in MESA. They only had fasting glucose, and if somebody was taking a diabetes medication. That's how we classified those with diabetes when we compared to MESA. And again, the South Asians shown in orange had the highest prevalence of diabetes compared to all 4 groups, including the Chinese, the Blacks, and the Hispanics in MESA. And this is unadjusted, raw, crude data analysis, just looking at who has diabetes and who doesn't. But then when we adjust for things like socioeconomic status, I already told you education and income are much higher in the South Asians. So when we adjust for that, can we explain away some of the differences? We also adjusted for other metabolic factors like BMI, waist circumference, HDL cholesterol, triglycerides, insulin resistance. All these things could not explain the difference. In fact, the differences only got larger with more diabetes in the South Asians compared to the other groups in MESA. So why is this happening? Why is there so much diabetes? And this has been seen around the world, in the UK, in Singapore, in other studies from South Africa, that there is this very high prevalence of diabetes in South Asians in any diaspora country. And currently, estimates in India are quite shocking. They're in the 250 million range. So more than 14% of the Indian population of adults has been shown in several studies to have prevalent diabetes. So why is this happening? So we looked at people without diabetes to understand, is there differences in insulin resistance or beta cell function? And these curves show you HOMA insulin resistance, a surrogate measure of insulin resistance for the South Asians shown in orange-red color compared to the 4 groups in MESA. And this is across the years of data that we have from age 40 to 80. And what you'll see is the South Asians have higher levels of insulin resistance up to the age of 65, and then the levels do drop off, but much higher than the other groups. Whereas beta cell function measured by HOMA beta was much lower for the South Asians across the board at every age compared to the other groups in MESA. So not only is there this insulin resistance that has been shown in many other studies from around the world, but there's this preponderance of having poor beta cell function. And that has actually gotten very little attention in the past. Like, what is going on with so much lower beta cell function? Is this something that may be genetic? Is this something environmental? Or is this a combination of genes and environment causing poor beta cell function, causing quicker advancement into diabetes because the pancreas gets exhausted? So let's look at the people with diabetes, now putting together people with diabetes in both MESA and MASALA. So there's about 1,300 people total who had diabetes in these 2 studies. And we looked at their clinical variables. We wanted to look at the different type 2 diabetes subtypes. You may all have seen a lot of the studies that started coming out in 2018, 2020 about how type 2 diabetes isn't one type of disease. There's actually many different subtypes, and some are less aggressive than others. And so we wanted to look at that in our data. And what we found was that there's mainly 5 major clusters of subtypes of diabetes. The most common one was an older age at diabetes onset, and that was seen in about 44% of people. And this is, using MESA and MASALA together. The second most common subtype was one that had severe hyperglycemia, very high hemoglobin A1C levels, and very low beta cell function. So this beta cell exhaustion causing very high hyperglycemia in a normal or lowish BMI population. And the third most common was a severe obesity, very insulin resistant subtype. And the fourth one was the type of type 2 diabetes that has really exhausted the pancreas, causing insulin to be needed. And then there was a very small proportion with really young age at onset type 2 diabetes. So when we look at these 5 subtypes, the question is, does the distribution of these subtypes differ by ethnic group or ancestry? And in the far right panel, I'm showing you the distribution of these 5 subtypes in the South Asians. And the most common subtype was not the oldest age at onset. That was only 29% of the people with diabetes in MASALA. The most common was this severe hyperglycemia, the beta cell exhaustion type of type 2 diabetes. And then the third most common was the insulin-resistant type. And if you look at the Chinese Americans in MESA, you can see a very, very different prevalence of these subtypes, where the older age at onset was the most common, vastly most common subtype in the Chinese Americans. And the next was this beta cell exhaustion type with severe hyperglycemia, and then the insulin resistant. And you can see how, you know, these subtypes exist in all groups, but it's the distribution that's different. And South Asians really stand out at having a very different distribution, probably most similar to the Latinos rather than any of the other groups. So what does this mean? So why does it matter that we understand the type of type 2 diabetes someone has? That's because there's clinical implications. If we know that our South Asian patient is most likely in the severe hyperglycemia subtype, we found that these people here have the highest incidence of developing coronary artery calcium or atherosclerotic plaque after 5 years of follow-up, much higher than any of these other subtypes. So these are the people with the highest risk of developing atherosclerosis and likely cardiovascular events. And so maybe we should be treating our type 2 diabetes South Asian patients who have, you know, more likely this subtype with the newer agents, and foregoing the older agents that really don't have much of a protective effect on cardiovascular risk. So SGLT2 inhibitors, GLP-1 agonists may be a better drug to reach for as first-line agents in people with diabetes who are South Asian. The second most common subtype was at older age. We found very few aggressive outcomes like CKD, atherosclerosis, almost nothing. And that means that people who develop type 2 diabetes, even if they're South Asian at an older age, by that I mean over age 65, those people may not need very tight control, or they may be able to do fine with less aggressive medication control. And then the third most common group was the severe obesity group with the insulin resistance, but we found they had no higher risk of developing CKD or atherosclerosis, and maybe these people would be better treated with weight loss, metformin, potentially the GLP-1 agonists because of the weight loss, and some other insulin sensitizing agents. So going on to talking about body composition, we used body mass index as a surrogate measure of adiposity. And here I'm showing you BMI categories for normal weight using the Asian cut point of 23 for the Chinese in MESA and the South Asians in MASALA, and 25 for the other groups. Overweight is 23 to 27.4 for Asians and 25 to 30 for others. And then the BMI over 27.5 is obesity for Asians. And what we find is if you look at the orange panel for the MASALA participants, the prevalence of normal weight was about 25%, intermediate to the other groups. Chinese had the largest prevalence of normal weight. Almost 40% of Chinese were in the normal weight category. Overweight was fairly similarly distributed with about 35 to 45% prevalence, and MASALA is right up there with about 45% having overweight. And obese, again, here's MASALA participants right in the middle with about 30% prevalence of obesity. So obesity is definitely prevalent in South Asians, but not as much as compared to the African Americans or Latinos. And certainly the Chinese had the lowest prevalence of obesity. So I went through this exercise to not only show you the distributions of these BMI categories, but I really wanted to dig into this group here, the normal weight people. Because as you know, the American Diabetes Association and the US Preventative Services Task Force does not recommend diabetes screening for people who are in the normal BMI range. And I wanted to look at that a little bit more carefully. Is that true? Should we not worry about these people with normal BMI? So when we categorize people, again, by their BMI classes, but then we looked at how many had any metabolic abnormalities. By that, we're using 2 or more of the NCEP3 criteria for metabolic syndrome, so high waist circumference, high blood pressure, high triglycerides, or low HDL. And what you're seeing here in the normal weight category, that red bubble shows you that the South Asians had about half who had metabolic abnormalities, even with a normal weight. But this exists in all groups. So even the whites, about 20% had metabolic abnormalities with normal weight. And the other groups, it was between 30 and 35%. So just South Asians had more metabolic abnormalities. So this, if anything, it tells me that we cannot give a pass to those in the normal or less than 23 BMI because there's still a lot of metabolic abnormality. So what is a BMI that may be equivalent in a South Asian compared to a white who has a BMI of 25? And when we did a modeling exercise to look at this, we found that a BMI of 19.6 in South Asians was roughly equivalent to a BMI of 25 in a white person to have the same number of metabolic abnormalities. And the take-home message for me is that a normal BMI does not mean a low risk of metabolic risk factors. And if, patients or participants, say like, what is a BMI that I should be kind of reaching for? What would be a more normal, BMI level for someone with my, genetic ancestry background? The data is fairly clear, and this is coming from here as well as from Canada as well as from the UK, that a BMI less than 20 is ideal for many in the South Asian region. All right, so let's talk about ectopic fat. I think this is really important because you've all heard of the thin fat paradox in South Asians, and so we wanted to really examine this closely with the best measures that we could. So we use CT scans to look at fat in the muscle, fat in the liver, fat around the visceral organs, and fat around the heart. And we use the same CT measures and reading centers at MESA because we wanted to compare where the fat was in each of these groups and compare the groups. And what we found was clear that South Asians store more fat in the wrong areas. So this is a measure of hepatic attenuation. So this is fat in the liver. Lower levels of attenuation means more fat in the liver. South Asians, shown in orange again, have the lowest hepatic attenuation, so the most fatty liver compared to all of these other MESA groups. There's more visceral fat. There's more muscle fat, fat in the muscle where it shouldn't be in the South Asians, and much lower lean muscle mass in the South Asians compared to the groups. And you can say part of this could be because they're not exercising. Very, very, very likely. There may also be genetic origins to low muscle mass, but this is definitely something that is problematic because we know that these ectopic fat depots can lead to metabolic derangements, can lead to diabetes, and even cardiovascular disease independently of other risk factors. What about hypertension rates? They were highest among the Blacks in MESA and second highest in the South Asians in MASALA. How about cholesterol? This is the typical clinical panel of fasting lipids. And I just want to make the point that we did not see that many abnormalities here. On average, the HDL was not lower. In fact, it was much lower for Latinos and Chinese than for South Asians. Triglycerides were not higher. They were actually moderate. They were much lower in Blacks and much higher in Latinos and Chinese. And this is taking out anyone taking any statins or any other cholesterol lowering medications. So the general typical lipid panel really didn't show that many abnormalities. And you're all going to say, well, of course, I mean, we all knew this because we know that there's more, small dense LDL, and there's more problems with LP little a. Yes, there definitely is differences in LP little a. So here is the LP little a concentrations in South Asians were 17 compared to 13 in the other groups, but I will show you that they were 35 in Blacks. And yes, there may be some differences in LP little a and the genetic polymorphisms that lead to higher levels of LP little a for Blacks versus South Asians. And that's something that Dr. Anurag Mehta is definitely interested in pursuing in looking at our data. What we have found with LP little a levels that are high in South Asians is that there was no association between LP little a and our measures of atherosclerosis, looking at coronary calcium in the heart or the carotid IMT. We also found no association with LP little a and aortic valve calcification, which has been seen in many other populations. So this is intriguing to me, and in some of our early, understanding of LP little a is we've seen that higher LP little a was actually associated with increase in the density of coronary plaque over time. And having a more dense plaque is actually favorable because it leads to less plaque rupture and less myocardial infarction. So there's something going on with LP little a that is not so clear cut in my thinking, and we are going to be interested in looking at long-term associations of LP little a with cardiovascular disease events in MASALA. So let's talk about diet, because everyone has their own pet hypotheses why there's so much heart disease in South Asians. So diet was very, very important for us to measure and measure well. So for MASALA, we used a very complicated food frequency questionnaire that was developed by the SHARE study in Canada. It had 164 items. Imagine sitting there and answering a questionnaire about your diet that has 164 questions. It was painful. It takes 45 minutes to an hour, but all of our participants did that at first exam and again at second exam. And so Dr. Gadgil took our data and combined the foods into 29 different groups and weighted it by serving size and did a principal components analysis to come up with what are the dietary patterns that our participants are consuming. And she found three main dietary patterns. One is an animal protein diet that's rich in alcohol, coffee, eggs, fish, pasta, so lots of American Western foods in this pattern. The middle pattern is more one that is a traditional South Asian diet with fried snacks, sweets, and high-fat dairy. And again, a lot of these foods are mostly vegetarian. And then the third dietary pattern was one that's rich in fruits, vegetables, nuts, and legumes. Again, primarily a vegetarian diet. And what she found was these three dietary patterns were associated with very different risk profiles. The animal protein diet had a higher total and LDL cholesterol, higher weight, and higher waist circumference, and more fat in the liver. The people eating mostly this type of diet had lower HDL and higher insulin resistance, so much more of a metabolic syndrome type of pattern compared to this more healthy dietary pattern that had the lowest rates of metabolic syndrome and hypertension. In another analysis led by Dr. Bhupitharaju, who's at Harvard School of Public Health, she categorized all of the vegetarian plant-based foods that people are eating. There are 43% of people in MASALA are lifelong vegetarians. So this is a very nice opportunity to look at healthful vegetarian diets versus less healthy vegetarian diets. And so she categorized how much people were eating in the healthy plant-based foods, whole grains, vegetables, nuts, legumes, and the less healthy refined grains, fruit juices, more of the starchy potatoes, deep fried snacks, desserts. And what she found was that the more of the healthy plant-based diet, and that's shown in green, the less there is fatty liver, the less obesity, less overweight, and less risk of developing type 2 diabetes after 5 years of follow-up. People eating more of the unhealthy plant-based diet had no real elevated risk of these things, but almost a slight trend towards higher risk of developing diabetes. So this just gives us more evidence that we need to not only stop by asking people what they eat. Are you eating, mostly plant-based foods or vegetarian diet? The diet quality really matters. So digging deeper into what do you mean by a vegetarian diet? What are you doing? How do you cook your food? Are you deep frying your food? What kinds of oils are you using? How are you, what kind of vegetables are you eating, and how are they cooked? So I want to show you some of our acculturation data, because I think this is unique to Masala and really is very, I think, super interesting for all of us who are living in the United States and who may have children and grandchildren growing up here. So we were very interested in looking at the influence of living in the US on how culture changes and how that may influence behaviors. So we used 9 different measures of cultural items: how long someone has lived in the US, how well they speak English, then what kind of foods they're eating in and out of the home, how often they're meeting with people and doing social, cultural, religious events, how frequently are they shopping at South Asian markets, who are their friends, what languages do they use at home and when they read media. And this traditional cultural belief scale is something that we developed. And what we found when we put all this data together was that there's 3 main types of acculturation strategies. And what I'm showing you is this Venn diagram showing you there's a big overlap. So there's people who are very South Asian in their beliefs and behaviors, and those people are in the separation class. And almost 20% of our study population is in that very traditional South Asian. More than about half are in the bicultural, the integration class, where they've adopted some behaviors and beliefs from the US, but retained some from their sending country from South Asia. And then there's people in this light blue arc, which we call the assimilation class. Now, these people have adopted many more of the beliefs and behaviors of the US and not kept many of the South Asians. And about 1/3 or 30% of our participants fell into the assimilation class. And what we found in these different classes is people in the separation class were more likely to be women, had fewer years that they lived in the US, so they're more recent immigrants, about an average of 22 years. They had lower socioeconomic status, so lower education, lower income, less exercise, but also some healthy things. They were smoking less tobacco and drinking less alcohol. And they were eating more of that traditional South Asian diet, that middle diet that I showed you. About 56% were eating that traditional South Asian diet. People in the assimilation class had been in the US for many more years, 32 years on average, had higher education and income, had more exercise, were doing more exercise because they were assimilating. Because they had higher SES, they were assimilating in possibly healthier ways, right? Adopting more of the exercise behaviors. They were also smoking more, and they were drinking more alcohol, and they were eating more of the animal protein diet. That was the predominant dietary pattern in this group. So what does this mean? So when we looked at their risk factor profiles by these 3 classes, again, the most South Asian in orange, the most American in blue, and then that bicultural group in the middle, what you can see is that the least healthy profile was in that most South Asian or separation class, the highest BMI, waist circumference, most diabetes, most hypertension, and the most fatty liver. And the more healthy profile was the assimilated one, with the lowest BMI and lowest diabetes and lowest hypertension. And this integration group was intermediate to the 2. Well, that's not the full picture. That's cross-sectional data. We can't really say much about causality with cross-sectional data, but now we've been able to look at what happens after 5 years of follow-up, and there's a little bit more nuance here. So looking at those same groups of people, what happens after 5 years? Well, the people in the separation class, the most South Asian, had greater change in their fasting glucose, so that's bad. They were higher fasting glucose levels by 7 in 5 years. But the people in the assimilation class had the most weight gain and waist circumference gain. And the change in coronary calcium was worst in this separation class. So if there is a healthy profile here, it's that bicultural group that had kind of the most intermediate change of all of these risk factors. So stay tuned. We're going to be doing a deeper dive into this now that we have 10-year data that we are looking at. So I'm going to end by talking a little bit about our atherosclerosis data for the last few minutes. And as you all know, this is a cross-section through the heart with the whites showing you the calcified plaque in the coronary arteries. And calcified plaque, or CAC, is very early in the process of atherosclerosis. And as you know, that it takes, a vulnerable plaque to rupture, to cause a thrombus formation, to eventually cause a myocardial infarction. In many populations, a burden of calcified plaque, or CAC, is associated with who develops heart attacks in the future, and it's independent of all of the other risk factors like cholesterol, smoking, hypertension, diabetes. So we were very interested in looking at CAC in South Asians, and going into this study, my hypothesis was that the CAC in these South Asians will be higher than most of the groups in MESA, because we expect that the South Asians would end up having higher risk of cardiovascular disease. And what did we find? What we found here is men shown in the left panel and women in the right. I'll point out that the CAC scores were very different by gender. For men, this is up to 400. For women, it's only up to 100. And the South Asians are shown in red, and the other colors represent MESA. There's virtually no difference between the South Asian men and the white men. So the CAC prevalence by every age group is almost identical for South Asians and white men. Whereas for women, there's really no significant difference between any of the groups, because these CAC numbers are very low for all of the women. Even in their 70s and 80s, the average CAC is in the 20s. So similar CAC burden for South Asian and white men, and similar CAC burden for all women. And what happens after 5 years? We brought everyone back and we remeasured calcium. Oh, before I go on, I do want to say that there is a difference in how glucose affects CAC. And in these curves here, we're showing you the effect of glucose here from 80 to 330, and of hemoglobin A1C, lowest levels to highest levels. And the purple line is the South Asians in MASALA. And you'll see the slope of the purple line is steepest here for both glucose and A1C. And that is the effect of glycemia on CAC scores was much stronger. And this goes back to my earlier paper that we showed you about diabetes and subtypes of diabetes, that people with high glucose or high hemoglobin A1C were the ones that were having the most progression of their CAC. And this just reinforces that glucose has a more adverse effect on CAC progression or CAC burden in South Asians than on other groups. So after 5 years, we brought back our participants and we looked at CAC again, and we found that the South Asian men had faster change in CAC than all the other men in MESA. But when we adjust for other traditional risk factors, there was no difference between the white and the South Asian men. Again, they were very similar. And again, there was no difference in all of the women compared to South Asian women. And we found the same risk factors played a role in who had more CAC progression in 5 years. Lastly, I want to end by showing you our newest data that is looking at the Bangladeshi and Pakistani immigrants. And we have sampled people who live in the New York City area, as well as Chicago, to add about 1,200 new Bangladeshi and Pakistani participants to MASALA. We're about to finish that arm of the study in a couple of months. And just showing you that South Asians are not a monolith, here's our preliminary data looking at diabetes, prediabetes, and normal glucose. And you'll see here's the Indian data with about 24% of Indians in our original MASALA study that I've been talking about all along have diabetes, but look at the prevalence in Pakistanis, 44%. And look at Bangladeshis, 1 out of 2 Bangladeshis have type 2 diabetes. That is very high. That's on the order of what Pima Indians in the United States have, 1 out of 2 with diabetes. Hypertension, the same type of graded effect, with the Indians having the lowest prevalence and the Bangladeshis having the highest, and Pakistanis in the middle. So The whole point of us doing this is to be able to compare profiles between these three different country of origin groups and to look at why there are these differences. We don't think there's going to be important genetic differences between these groups. As I showed you, genetic ancestry is on a continuum from north to south. This is going to be all about social, cultural, behavioral differences that amplify the underlying genetic risk. And so we hope to be able to flesh this out in the coming years. I want to end by pointing out this very nice review article that was done for prevention people who are seeing patients and want to know, what should I do differently when I see my patients, and how do you risk stratify people? And so this brings together all of the information we've learned in MASALA, as well as other studies from around the world. So I invite you to look at this paper a little bit more carefully. And that was published last year. Agarwala is the first author, and it was published in JACC Advances. And with that, I'll conclude by saying South Asians have a lot more diabetes than other groups. There's high beta cell dysfunction, high insulin resistance, and lots of ectopic fat, especially in the liver and the muscle, and low lean muscle mass in the South Asians in MASALA. There's a high Lp(a) burden and a high CAC burden, especially in South Asian men. And contrasting South Asians to other ethnic groups really helps us expose disparities and shows us like the big differences in the heterogeneity of disease, opens avenues to prevention and treatment. And we need to do a better job at disaggregating South Asian data, because there are some very important differences that we are hiding when we aggregate them together. And with that, I thank our participants and all of our investigators and funders for MASALA, and I'm happy to take some questions.
Thank you very much, Dr. Kanaya. This was fantastic. We have many questions in the chat. If you're okay, I would like to start with one. Phenomenal presentation and summary of all of the data. From a atherosclerosis standpoint, this is something that we've learned from other multinational investigations, that Indians or South Asians tend to develop coronary heart disease or their first MI at a much younger age, up to a decade earlier than other groups. But in the comparisons between the MASALA study and the 4 ethnic groups within the MESA study, there doesn't seem to be a significant difference in coronary artery calcium. Do you think that there is a potential role of more vulnerable non-calcified plaque or inflammation around coronary arteries, or any other mechanism that could be driving that?
That's an excellent question. So we found that South Asians and whites had the same CAC burden in MASALA and MESA. The other 3 groups, Blacks, Chinese, and Latinos, had much lower CAC burden. So how can we explain that we expect to see much higher cardiovascular risk, but the CAC wasn't higher as we had hypothesized it would be? And this actually has been replicated in other studies around in the Netherlands, as well as in another US population, where the South Asians and the whites have very similar CAC burden. I expect that there may be more vulnerable plaque. There may be more extensive plaque. And some of our papers that I didn't have time to go into have shown that South Asians seem to have many more coronary arteries that have plaque than other groups. So it could be an overall burden situation that is higher because of the distribution of the plaque and the plaque characteristics. So we hope in the future we will get funding to be able to look at soft plaque as well as other plaque characteristics to understand this better.
Thank you so much. The questions from the chat, Dr. Kanaya, the first one is from Dr. Gupta. Almost all of my patients in cardiology practice, they are on statins, and nearly all of them who didn't start with diabetes are now in the pre-diabetes range, a hemoglobin A1C between 5.8 to 6.4%. Do you see this as a causal effect?
Yeah, so there's been meta-analyses of these, looking at all the trials of statins and primary prevention, secondary prevention. Most statins are associated with about a 2 milligram per deciliter increase in fasting glucose levels. So that has been well established in trials. And so you seeing someone progress a little bit from pre-diabetes to a little bit further pre-diabetes is expected. But in general, we know that being on the statin has much higher benefits than risks. And again, if someone just crosses over the borderline because they go from 6.4 to 6.5, there's nothing magical about that crossover. And you know, if they are getting the benefit that they need from a statin because they have high coronary calcium or other, you know, high risk factors for atherosclerosis, then I think the benefits of statins way outweigh the risk of slight glucose increase.
And Dr. Kanaya, are there investigations that have looked at ancestry-based differences in this risk of dysglycemia with statin therapy?
Oh, I'm not aware of any. That's a really good question. Anurag, do you know?
No, I don't. And it just came to my mind when I read this question that, you know, this would be something very interesting to
We could
see,
look
you know,
at
if you
it.
come. Yeah. The next question is from Dr. Bhatt. Are Southeast Asians genetically predisposed to higher incidence of type 2 diabetes? Is there any validity in attributing it to the starvation gene that our ancestors developed and passed it on?
Yeah. So I will correct you. It's not Southeast Asians, it's South Asians. Southeast Asians implies Indonesians and people from Malaysia and that part of Vietnam, Laos. And so please use South Asians for talking about people from the South Asian Peninsula. We need to correct each other, so we're all using the correct terminology. So in terms of type 2 diabetes, there was a fantastic new study that just came out last week that I did not add to my slides. But it was a genetic study done in the UK. They have a study called Genes and Health, and it's Pakistani and Bangladeshi. So there's no Indians in that study, but it's 50,000 Pakistanis and Bangladeshis. And they looked at type 2 diabetes genes. And what they did is they looked at partitioned polygenic risk scores for diabetes. And they found that there's two very predominant ways that people develop diabetes. And it is one, beta cell exhaustion, what I've been telling you, that we've been seeing that there's low beta cell function, and this is something that may be inherited. And they found that beta cell dysfunction was the most common form of the genetic makeup that caused type 2 diabetes in these South Asians. And the second was insulin resistance, having fat in all the wrong places. So kind of exactly what we've been seeing all along in our study. And they found the genetic basis of that. And they took what they found and they checked it in a second independent study, the UK Biobank study that has mostly Indians, and they found the same two genetic predispositions. So I think there's absolutely these two forms of genetic predisposition, but that does not mean that we cannot do something about it. Genes prime us to have this, you know, disposition to develop diabetes if we have, you know, we fall in these two buckets. But there's many things that can be done in terms of diet, exercise, and other ways to modify that risk.
The next question is from Dr. Patel, something that relates to discussing findings for weight and weight management with our patients. Dr. Patel says, being overweight is considered affluent and happy. These are cultural norms amongst Indians. Eating fruits and vegetables is considered as being poor.
Yeah, not anymore. I think if you tune in to Bollywood in India, I mean, now it's all about being fit and showing your abs and having the six pack and like even the women, you know, being fit. And I think we need to change these cultural norms because it's clearly not serving us being overweight. And, you know, and now actually in India, we've kind of reached a tipping point where you see that the higher weight, the higher affluent groups are the ones who are actually going to the gym. They can afford a gym membership because no one can exercise outside with the pollution the way it is, or the streets and the traffic, or, you know, other reasons for being able to exercise outdoors. So it's that affluent group that's going to the gym and exercising and worrying about their health. And so I think they've started to kind of move into the more understanding. And so I think we have a lot of work to do. And like I showed you with our acculturation data, that the people who are assimilating to the US were the ones who were exercising more. So we need to, as healthcare providers, as clinicians, this is up to us and to, us to use our networks to spread the word that we're not doing any favors by being overweight, right? Normal BMI, less than 20.
All right, that answers actually our next question from Dr. Gupta. My goal for BMI used to be 23. Are you suggesting that we should use 20 for South Asians? So the answer is yes.
Based on our data, based on the metabolic data, the lower the better, honestly, but it's also about how you get there. If you're getting there by starving yourself and losing muscle mass, or taking GLP-1 inhibitors and agonists, to lose fat that that you may not need to, that's not the right way to do it, right? So by doing it in a healthy way where you retain muscle mass and lose weight, that's absolutely ideal.
The next question pertains to the relationship of Lp(a) with CAC in South Asians. So the question is, are you saying that Lp(a) is not a marker for premature and severe coronary artery disease in South Asians?
No. I'm not saying that at all. I'm just saying that in our study, we found that despite having elevated levels of Lp(a), we did not find any associations with plaque or with the other aortic valve calcium. And so other studies have shown strong associations with Lp(a) and having cardiovascular events. And we expect that we will find that as well. But in just looking at the way that Lp(a) may work is probably not through plaque. It's probably got its own inflammation and prothrombotic activity that may make the plaque more vulnerable to thrombosis and events, rather than working through, causing plaque buildup. That's my assumption, is that the mechanism is very different. Anurag, does that jive with what you know?
I think so. I think like an assessment with, for example, a coronary CT angiogram, or plaque distribution, vascular inflammation, those kinds of things might provide more insights into the role of Lp(a) and cardiovascular disease in general. The next question, Dr. Kanaya, do you have plans to include more people who are born in the US in this study, or do another similar study as MASALA? Because these individuals, they have South Asian genes and American dietary and other habits.
You read our mind. We're doing this now. So we've invited the adult children of our MASALA participants to a second-generation study. Dr. Nilay Shah at Northwestern, he's leading this study. It's called the MASALA 2G second-generation study. He's already enrolled about 100 of their adult children. These are in their 20s and 30s, because we really are interested in what happens to the second generation. Are they going to be so assimilated that they actually may have some, bad behaviors in terms of diet? We're seeing, higher trends towards gaining more weight because of that animal protein diet being more popular. So so we are very interested in doing that, and hopefully, we can get more funding to actually expand that and have other have more people who are young and born in the US join the study.
And that is excellent, Dr. Kanaya. Next question is, what was the difference amongst Gujaratis? I believe Dr. Siddiqui is referring to the principal component analysis for the genetics data.
Yeah, so I've shown our data. That's our genetic ancestry data. So what we do is, we look across the whole genome, because we've done whole genome sequencing, and we take out thousands of SNPs that are related to genetic ancestry. And then we do a principal components analysis to look at what clusters together. And we found there's one line that basically north to South Indian and north, like Bangladeshi, Pakistani, North Indians, and then South Indians and Sri Lankans, they're all along one line using two principal components to explain differences in genetic ancestry. And then there was this independent cluster from Gujarat. And I've talked to some genetic experts from India about this, and they've seen this in Indian data. And we're waiting for the release of the 10,000 genome project in India that's expected sometime in December or January, in the next 2 months, so we can have a better reference panel to understand, is this truly something different? Because are there founder genes or differences in Gujaratis that may explain this separate cluster, that there's different, genetic patterns that have been inherited in that group. And so the verdict is out, but I'm still waiting to understand this a little better by by seeing more. That's a problem with, South Asian data. South Asians represent almost 25% of the world's population, but less than 2% of the genetic data that we have in any scientific studies come from South Asian. So we don't really know. I can't say, we're using reference panels that have only a few South Asians in it. So I don't know what the normative data are yet.
The next question from Dr. Sahota is, are there similar differences seen in cerebrovascular disease as well?
I wish I could answer that question. We've had many of our participants have gone on to have stroke in MASALA, but it's not as common as heart disease. It's much lower, and East Asians seem to have a much higher incidence of developing stroke than South Asians. And I think part of it is that, hypertension is probably the most important risk factor for stroke, and smoking and other risk factors. And if your hypertension is well controlled, and in the US, in our population of very, highly educated, affluent Indians, most had pretty good blood pressure control and were on 1, 2, 3 blood pressure medications. So we're not seeing that much stroke in our population.
Right. The next one is from Dr. Saraya. Was there any measurement of stress and/or sleep as a contributor to the risk of coronary artery disease?
Yes, we have measured stress with different questionnaires. We've measured chronic burden. We've measured other types of psychological distress, discrimination, anger, anxiety, depression. And we've seen some important associations with atherosclerosis, with carotid atherosclerosis, as well as with CAC. We don't have great measures of sleep. We've been trying to get a sleep study funded, but it hasn't been easy. We have questionnaire measures of sleep in terms of, just sleep quantity, but not good measures of sleep quality. So I cannot answer that question.
All right. The next question from Dr. Peruri. Can we reverse these tendencies with a vegan diet?
That's the big question, right? Unfortunately, we don't have good data, right? Because you'd have to lock people up and have them eat a certain type of diet for many, many, many years to be able to see an effect, because, very hard to do these studies. And the best evidence we have come from these longitudinal cohort studies or short-term trials where you give people food to eat for 12 weeks, 20 weeks. And from studies that have done that, we do see that there are real benefits on cardiometabolic profiles and on plaques. And so I think having, a lower fat and lower carbohydrate diet with high protein from plant-based diets, that if I talk to the experts who work in this field all the time, Nita Faruhi is an expert at Oxford University. I spoke with her last month when I saw her at a meeting. I spoke with Salim Youssef from Canada. These are people who, spent their lives trying to untangle this diet conundrum. And the best diet they can say is a modified keto diet that is more plant-based rather than, a animal-based. And that seems to be the sweet spot, is like all keto is not good. And modified keto is like 45% carbs and more plant-based protein and low in saturated fat.
Next question is, any correlation of CAC score with events in general in South Asians?
Absolutely. So we've just done preliminary look at this data. We hope to be able to do a full analysis in 2025, now that we have crossed over 100 events in our original population. CAC is very strongly associated with who develops heart disease. It's going to be one of the strongest predictors of heart disease in South Asians.
All right, the next one is from Dr. Govil. Do South Asians in general have a different risk profile compared to similar cohort of South Asians living back in their home country?
Yeah, so we've been partnering with an ongoing study in India called the CARS study. It's not all over India. It's only in 2 locations, in Delhi and in Chennai. And we found some very interesting similarities and very striking differences. For the first time of any studies being done, we find that the South Asians in India have higher diabetes prevalence than the South Asians in Masala in the US. And this is using the same age groups, using the same time period, using 2-hour glucose tolerance testing. The prevalence of diabetes is now higher in Indians than it is in the Indian immigrants in the US. And that's very frightening, right? It's like what is happening in these countries where diabetes is exploding. And so, yes, I think a similar, so they're doing CAC right now in that study. They're going to be comparing their CAC to ours and many other, we've compared our chronic kidney disease, finding that there's probably a little bit more kidney disease in the US immigrants than in the Indian natives in the CARS study. So yeah, we have much more to do.
Next question from Dr. Parikh. At what age may we start using CAC in a young Indian male with some risk factors?
Yeah, that's a really good question. We have a paper that's under review now that may help answer that question. So we put our data from MASALA together with a clinical registry from Dallas called the Dilwale study. And we tried to look at what normative data would be for people as young as 30 years old, South Asians between 30 to 84. And so we hope that we will have normative data in people who are younger than 40, because in Masala we have 40 to 84. So I definitely could advise you to start, thinking about getting CAC in your 40-year-olds, because now we know what the comparison is. The 30 to 40-year-olds who have CAC, who've had these CAC tests done, there's very low CAC burden, extremely low CAC burden in your average person. So I don't think there's that much good evidence to start doing CAC before the age of 40. And if you Google Masala CAC, you'll see we have these normative data by age that I showed you in those graphs, like what is an average 60-year-old CAC should be, what's an average woman and a man at whatever age. So please use those data to help. And then once this study is out, I hope you'll use that to look at normative data.
Right, we have another question from Dr. Singh. The prevalence of diabetes in South Asians is 17%, which is similar to other ethnic groups in the US. So why the coronary issues? Is it the diabetes subtypes that you discussed that are important?
Where did you get the prevalence with 17%? The prevalence of diabetes in South Asians in the US is much higher than what it is in other groups. We've disaggregated data from NHANES, we've disaggregated data from Kaiser. I showed you our Masala data. The prevalence of diabetes is 4 times higher in South Asians compared to whites. It's almost twice higher in South Asians compared to Blacks and compared to Latinos. So it is as high as Pima Indians for Bangladeshis, right? So definitely, I think diabetes is driving this atherosclerosis and cardiovascular risk. I think it's starting from before diabetes, so even pre-diabetes can drive it. And what we found was the people who have this hyperglycemia subtype had the highest risk of developing coronary calcium and plaque.
All right, the next question, Dr. Kanaya, related to diet. Any data on intermittent fasting or prolonged fasting for reversing diabetes or reducing cardiovascular risk?
Yeah, there was a small study done in the UK by my friend Naveed Sattar looking at reversal of diabetes in South Asians using a low-calorie diet and a lot more exercise. And it looks like, they're definitely, it is feasible. It is feasible. It takes a massive reduction in caloric intake, like under 1,000 calories per day. But it is absolutely feasible. And goes back to the idea that, if there's fat in these ectopic depots, if you lose fat in places where it shouldn't be, that the metabolic milieu changes and improves. The GLP-1 studies have also shown a regression of diabetes in people who start taking GLP-1s, at onset of diabetes. I think GLP-1s are going to be a treatment for, pre-diabetes in the future as well.
Thank you so much, Dr. Kanaya. One question I had for you, Dr. Govil. We are 11 minutes beyond our hour, and there are plenty of questions left. What are your thoughts? Should we keep going, or in email? What would you recommend?
Yeah, I would say go another 5 minutes. Just you can go through them very quickly if there's anything.
All right, let's see.
Be picky.
Yeah, we talked about coronary calcium.
Apologies if we miss out on any question. Please send us an email. Yeah, we'll get those answered.
One from Dr. Vidge is, what are your thoughts about if the body roundness index, I think they're referring to visceral adiposity, is it better than a standard BMI for South Asians?
Yeah, no, waist circumference is definitely better. It's just very hard to measure clinically. It's not easy to measure in research studies because the reproducibility is very low for waist circumference. So I don't know how to operationalize this in my clinic when I see patients. It's very, very hard to measure correctly. And so I think we need better surrogate measures of obesity because BMI doesn't do much to help us here. But at this point, I don't think waist circumference is a good marker to use in practical practice.
All right, next one is, beyond diet and exercise, what other factors can modify the excess genetic risk in South Asians?
I think someone else brought this up, stress and sleep. So it's those, stress, sleep, definitely diet, exercise, moderation on alcohol, lower the better, and smoking cessation. We all know those things, but sleep and stress have profound effects on appetite, on activity levels, on mood, on behavior. That's how they work, right? Is just so I think going back to the fundamentals that we all know, and it's boring to tell a patient that you got to work on your diet, you got to work on your sleep, you got to work, but I mean, that's what matters. And we're not only in the diabetes and heart disease world, for Alzheimer's, for cancer, for everything. It's like it comes down to these fundamental facts that we've all known for decades, and we just need to be better at practicing.
And the last one, I would say, Dr. Kanaya, as there is high prevalence of diabetes in South Asians, are you looking at urine albumin to creatinine ratio and its correlation or causation with the calcium score or unstable plaques that cause MI? This way, if we could find that relationship, we could do a simple urine test and link that to possible coronary events. It is cheap, it's point of care, and we can recommend lifestyle changes in those patients and how they do over time.
Yeah, we're looking at urine creatinine, we're looking at cystatin, we're looking at just EGFR measured through, the CKD equations that are currently not race-based. Yeah, we're looking at all of these different kidney measures, and when we look at events in our upcoming analyses, we'll be able to look at them separately and put them together and see what are independent risk factors. CKD is a very important part of this puzzle. And as you know, the American Heart Association now includes CKD in their prevent, guidelines and risks scores.
All right. And finally, Dr. Kanaya, I have two invitations that came up for you in the chat. One was from Dr. Katula in terms of the funding and expansion for the study, how the organization here could help. And the second one is an invitation, I believe, from the University of Missouri in their cardiology department for grand rounds.
Well, be happy to give grand rounds. I'm happy to do we are trying to disseminate, so if you can help me disseminate by taking any of I'm happy to share my slides with the organizers of this, and they can share it with the group. We have lots of these slides and talks are posted on our masalastudy.org website. We have a lot of patient-facing materials. We have health resources, videos. We have carb counting tools for South Asians with diabetes, like how much dal and what kind of dal and how many carb equivalents, like information you cannot find easily. Please go to our website and use these tools for your patients, for your family members, for yourselves. In terms of funding, I got to tell you, funding Masala has been a major challenge for us forever. And right now we are in the process of writing 5 grants at a time to try to keep, our funding going, because each grant, takes several iterations before it is funded, and many are never funded. So we would love to have any support from people who, if you have a network of people who are able to give us funding support, to, especially in times where we don't have infrastructure funding to keep our study going. And we try to contact participants every year to see who's developed heart disease, and we have gaps in funding. We are always, happy to talk to people who may want to, provide philanthropy to us and help us with MASALA. If you have connections to people who would be interested, I'm happy to pitch to people as well. And then, yeah, grand rounds, happy to do grand rounds at any of your organizations if you have other people who may benefit from hearing some of this.
Thank you. Thank you. Thank you, Anurag, and thank you, Alka. And I'll let Dr. Petula finish it off. And meanwhile, I put the QR code in the chat box for people to get the CME credit. And so please utilize that. And Dr. Petula, go ahead.
Thank you, Dr. Kanaya, for an excellent presentation. I have heard a lot of good things about you, but this is my first time listening to you. Awesome, awesome presentation. And thank you for educating us. And Dr. Anurag Mehta for wonderful moderation. We extended our time to 15 minutes, but more than 230 people stayed back. That shows how interested they are in this topic. And thank you, Amit Govil, for doing such a great job as a CME chair. And thank you all for attending. So it's a very important topic for all of us personally, for our families and friends and patients of South Asian descent. So we have a virtual plaque presentation for Dr. Kanaya. It's a small token of appreciation. Ms. Vijay, can you put that on, please? Yeah, American Association of Physicians of Indian Origin recognizes Dr. Alka Kanaya for her outstanding contributions in the field of medicine and cardiovascular health, and welcomes her as a member of API Distinguished Speakers Club. Satish Kathula, API President, Amit Govil, Chair, December 4, 2024. Thank you again. We really appreciate your presence here today and enlightening us with this
Thank
topic.
you. Thank you, Alka. Great presentation. Thank you, Anurag.
My
So
pleasure.
I will send you my slides, and please feel free to disseminate, and people can Google my name and it's easy to find my address, my email address if you want to contact me. Thank you.
Absolutely.
Right.
Absolutely.
Okay.
Thank you.
Thank you. Thanks, everybody.
Thank you.